Hi, I'm Sheila Reyes from the Philippines, and I'm reporting for Room Now here in beautiful Fukuoka for APLAR 2025. In this video, I will be sharing highlights and my key takeaways from interesting lectures on the treatment of gout. Dr. Lisa Stamp reviewed the role of SGLT2 inhibitors in gout management. These drugs have been proven in both preclinical and clinical studies to offer multiple beneficial effects rather for patients with diabetes, heart failure, and CKD. However, it is also increasingly becoming an attractive adjunctive therapy for gout patients with metabolic comorbid disease. So where exactly does SGLT2 inhibition fit in gout management? Based on the data from several studies presented by Dr. Stamp, SGLT2 inhibitors may play a role in mitigating gout flare risk, reducing gout flares, and decreasing urate production. Post hoc analysis of RCTs have shown the reduced risk of incident gout by dapagliflozin. Additionally, SGLT2 inhibitors exert their anti-inflammatory effects by inhibiting the activation of the NLRP3 inflammasome, thereby reducing gout flares. It contributes to urate production by decreasing purine synthesis and promoting the renal excretion of urate. However, according to Dr. Stamp, data on the serum urate lowering effect of SGLT2 inhibitors are mostly derived from secondary analysis of patients with diabetes or heart failure. Now, can this be a game changer, particularly in the treatment of gout patients with comorbid disease? Take note, however, that Dr. Stamp highlights the importance of conducting high quality RCTs that will validate these observations. And until then, we should continue providing individualized treatment to our patients. The key message here is that gout management doesn't just involve treating the inflammatory aspect of the disease, but also equally addressing comorbid illness in these patients. Now, in the same session, a multidisciplinary team approach in managing patients with gout was also discussed by Dr. Vinit Vaidya, which integrates patient education, imaging, dose adjustments, and comorbidity. Despite evidence-based treat-to-target strategies, Dr. Vaidya also highlighted gaps in gout management, such as adherence and motivation, or lack thereof, which clinicians should always consider, particularly when patients continuously have poor disease control. I'd like to emphasize some of the barriers to adherence that was mentioned in his talk because, in my opinion, as rheumatologists, we should at least try to address and clarify most, if not all of these with our patients or during every patient visit. Now, here's the list. First, the consideration of gout not being a chronic progressive problem. Second, patients not being fully aware of the cause of flares, or there can be confusions, including dietary triggers. I get that question a lot. Apprehension with long-term medication use and perceived side effects, and the use of alternative therapies. My key takeaway is this. Without a focus on patient education and managing expectations, our efforts are wasted. It doesn't matter how advanced a medicine is or what the latest guidelines suggest. If a patient doesn't take the treatment for whatever reasons, lack of education, difficulty in, in access, or poor compliance, we fail to achieve a positive outcome and are forced to start over and over and over again. Follow me on X at Boomerampa and tune into Room Now for more updates.